All right, welcome everyone. Welcome to the UNM Law and Mental Health Didactic Series. This series is hosted by the UNM Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so glad to have all of you here today to join us. I'm Tatiana Matlis. I'm an assistant professor and a forensic psychologist in the UNM Department of Psychiatry and Behavioral Sciences. For our talk today, please ask any questions that you have in the Q&A rather than the chat box anytime that you feel comfortable. But just know that we probably won't get to any of the questions until the end. Also, we always try our best to get to as many of your questions as we can. Please forgive us if we can't get to yours. For those of you who are looking for CEs but are on a tight schedule, you do have to stay for the full hour, but you don't have to stay any longer than that, even if we do go over. I'll try and let you know when the hour's passed, and we'll likely stay longer to address any of those questions. Again, don't have to stay longer if you're looking for those CEs. Anybody who's looking for CMEs, the sign-in sheet is in the chat box now. Anybody looking for APA CEs in the last 5 minutes, that will be posted in the chat box. Make sure you save your certificate after you complete the survey because we're not going to keep copies. And then lastly, the PowerPoint and recording of today's presentation will be sent in about a week. All right, and then for upcoming talks next week in the series, we will have Drs. Jason Lawrence and Molly Persky discussing evaluations for juvenile transfer to adult court. So we're really excited about that. All right, and then now it's time for what we've all been waiting for. So I'd like to introduce you to our speaker for today, who will be presenting on concussion as a mitigating factor in capital murder. So we have Dr. Shawn Acheson with us today. Welcome, Dr. Shawn Acheson.
Thank you. Thank you.
Yes, thank you for being here today. So Dr. Acheson earned his doctorate in clinical psychology from Southern Illinois University in Carbondale, Illinois in 1997. He completed specialized training in clinical neuropsychology during his pre-doctoral internship and post-doctoral fellowship in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center. He spent most of his career teaching and conducting clinical and preclinical research on TBI and the neurodevelopmental effects of alcohol and marijuana. In 2011, he joined the Duke Center for Psychiatry and Law and served as lead psychologist from 2015 to 2017. He also served as staff neuropsychologist in the compensation and pension and neuropsychology clinics at the Durham VA Medical Center from 2016 to 2017. In 2017, he returned to private practice in Asheville, North Carolina, where he provides clinical and forensic neuropsychology services in civil, criminal, and administrative courts. Shawn, on behalf of UNM, we're excited to have you join our series and are so thankful for you to be sharing your expertise with us today. So now I'm going to turn it over to you.
Thank you, Tatiana, and thank you to Julie Bravko and Anthony Perillo and Alexandra Pond for facilitating this whole process. I know this can be a complicated endeavor sometimes, so my thanks to all of you. And it's a pleasure to be here. I presented, I guess, 2 years ago on in the early stages of the COVID pandemic, and it's nice to be back and be amongst the individuals who presented in this forum. There's been some great speakers, and I hope I can contribute to UNM's weekly didactic series. So let's start talking about concussion as a mitigating factor in capital murder. Just going to click through some things, disclosures, disclaimer, the views are mine. I have no financial interests in the things I'm going to be talking about. The learning objectives. I'm going to describe the types and mechanisms of traumatic brain injury and their incidence in general and criminal populations. I'll describe the procedures for assessing concussion and typical time course and outcomes associated with concussion. And then we'll talk about the relevance of concussion to capital mitigation. With regard to cultural considerations, there are some age and sex-related factors that are important. We're not going to really delve into those very much today. In terms of cultural considerations, the reality is, unfortunately, that brain injury is an equal opportunity offender. It can strike anyone at any time. Those cultural considerations that are relevant in the practice of clinical forensic and neuropsychology are equally relevant in assessing and understanding the impact of brain injury. So all of those cultural considerations that we normally deal with are just as relevant. So let's talk about concussions as mitigation. I wanted to present this topic in this forum because this is really the first part of a larger project I'm working on for the North Carolina Office of Indigent Defense Services. And my goal in that project is to help educate lawyers, defense lawyers here in North Carolina about brain injury in criminal defense. I found remarkably little in the literature that specifically addresses the role of brain injury in capital mitigation. So I'm going to share with you my understanding of brain injury based on my years of experience in my training and what I understand about mitigation. And then I will talk about sort of my opinion as to the nexus between concussion and capital mitigation. My talk today is intended to be a relatively narrow discussion regarding mild TBI or concussion, and understand that those two things are the same. There is no demonstrable difference between a concussion and a mild traumatic brain injury. Some people will sort of try to talk about them as different things, but they're really one and the same. At least at this point in time, there's no meaningful distinction between a concussion and a mild traumatic brain injury. This issue, concussion as mitigation, this is without a doubt the single most frequent referral question I get from defense attorneys. It usually goes like this. Dr. Acheson, my guy says he had a brain injury. Will that help us at sentencing? And my answer is usually, let's see. I can't tell you without records, interviews, and an evaluation. In light of that, let's actually start at the end and then go back to the beginning. So the first thing I want to do is talk about mitigating factors, what mitigation is. In layman's terms, mitigating factors are those characteristics of the defendant or the defendant's history before or after the commission of the crime, or contextual factors relating to the crime that defendant may present at sentencing that jurors may consider in reducing the defendant's culpability. This notion of mitigation was really first presented by or discussed by the Supreme Court in McGaugh v. California in 1971. And in that decision, they determined that a defendant's history of childhood trauma and abuse are relevant factors for the jury to consider when deliberating their sentencing recommendations. The next major step regarding mitigation and mitigating factors occurred following their 1972 decision in Furman v. Georgia, when they brought a temporary end to capital punishment. That decision to end, at least temporarily end capital punishment, was based on their finding or their belief that capital punishment as it was constituted then, as it was practiced then, violated the 8th and 14th Amendments. Modern mitigation, our understanding of modern mitigation really happened in the wake of Furman v. Georgia. In 1976, SCOTUS wrote a decision in Gregg v. Georgia. And in that decision, they described a procedure in which capital punishment would meet constitutional muster if and only if it included, 1, objective criteria to direct sentencing and limit sentencing discretion, and 2, must allow the jury to give particularized consideration to the character and record of the convicted as they deliberate sentencing. Several additional cases following Gregg v. Georgia further shaped the nature and practice of mitigation in those states that reinstituted the death penalty. As a counterpoint to this subject of mitigation, prosecutors are also able now to present aggravating factors, which may actually increase a defendant's culpability in the eyes of the jury. And this will actually come back to this a little bit at the very end. Each state has its own list of statutory mitigating factors. Each of those states that has the death penalty has a specific list of statutory mitigating factors. Dave DiMatteo and his colleagues in their, I think it was 2011 book, Forensic Mental Health Assessments in Death Penalty Cases, describe some of the themes, although those statutory factors differ from jurisdiction to jurisdiction. DiMatteo and his colleagues outline sort of the common themes across jurisdictions. And those mitigating themes, or those themes to mitigating factors, include the defendant's relative age or youth, the defendant's lack of prior offending, defendant's limited role in commission of the crime when numerous other offenders were involved, the victim, circumstances which the victim participated in or consented to defendant's behavior, which resulted in the capital offense. Defendant reasonably believed his or her actions were morally justified. Defendant acted under extreme duress, pressure, or domination of another. The defendant acted under extreme severe mental or emotional disturbance. When the defendant acted with some degree of impairment that limited her or his ability to appreciate the nature, character, consequences, or wrongfulness of the offense, of the offensive behavior. And then there's almost always a catch-all final category. And that's written in different ways in different jurisdictions. But here in North Carolina, it might be its broadest form of any jurisdiction. And that final catch-all mitigating factor simply states any other circumstance arising from the evidence which the jury deems to have mitigating value. You can't get more broad than that. So the ultimate question is TBI, sort of the final broad question here is TBI, or can TBI be a mitigating factor? And sort of the theoretical answer to that question is possibly. TBI may lead to changes in cognition or behavior or personality that fit several of those statutory mitigating factors. But they don't always. They can, but they don't always. Many attorneys ask if TBI itself, independent of any brain injury related consequences, if just the occurrence, the idea, the fact that a TBI has occurred, if that is sufficient for mitigation. And I want to hold off on that question. I want to save that for the end. But again, that's the frequent question that I get. My guy had a TBI. Is that mitigating? So let's go back sort of to the beginning and talk about brain injuries. It's important to understand that brain injuries are not all alike. Outcomes following brain injury vary in significant ways depending on the nature and severity of the injury, as well as a host of other factors relating to the age and various characteristics of the individual. There are numerous ways we can classify or categorize brain injury. The first major categorization involves whether or not the brain injury occurred before or after an individual was born. Any brain injury that occurs after birth that's not considered genetic or congenital is considered an acquired brain injury. Acquired brain injuries may then be classified as either non or atraumatic, or they may be classified as traumatic brain injuries. Non or atraumatic brain injuries include things like anoxia, infections, strokes, tumors, metabolic disorders, seizure disorders, drug and alcohol effects, malnutrition. Those are all considered atraumatic or non-traumatic acquired brain injuries. The alternative, are traumatic brain injuries, and these occur as a result of external forces applied to the brain, with or without direct contact to the brain or to the head. And there are three general mechanistic categories of these traumatic brain injuries. Two are seen here on this slide, but generally the three are blast injuries, blast-related traumatic brain injuries, open or penetrating brain injuries, and closed brain injuries. Each of these mechanisms present with a propensity for unique features in terms of classification and outcome. They are not all alike. We discriminate between blast, open, or penetrating and closed because mechanisms and outcomes differ accordingly. It's also important to understand that these are not mutually exclusive. It's entirely possible for someone to suffer one or two or all three of these simultaneously. Having worked at the VA, it was not inconceivable that you could come across a soldier who was on top of a building in Afghanistan or Iraq, who was hit by the blast wave of a mortar, knocked off a roof of a building, sustaining a closed head injury when they landed, and then impaled themselves, and their head was impaled by a piece of rebar or some other debris from the explosion. So you can have more than one of these, and that's part of what really complicates our understanding of outcome and mechanism. Let me talk first about blast injury because it's not on this slide, unfortunately, but it is important, especially if you're working with veterans. The blast injury itself, the blast-induced brain injury, occurs as a result of exposure to high pressure waves, or the high pressure wave that's produced by high energy explosives. Not all explosives and explosions are the same. Blast injuries really are limited to the impact of pressure waves from high energy explosives. These are really limited to military personnel and contractors in war zones. They rarely occur in civilian populations or in civilian contexts. In the 15 years that I've been doing forensic neuropsychology, I've never come across a defendant with a history of blast injury. That doesn't mean they don't exist or won't exist at some point. It's just simply not something that I've ever come across. Let's talk quickly about open and penetrating brain injuries. These occur when objects pierce the skull and enter the brain itself. This, of course, is described and talked about most famously in the case of Phineas Gage. Phineas Gage is actually a remarkably complicated case because it's been used to illustrate or demonstrate very different outcomes. Early on, it was used to illustrate the idea that the brain injuries, the people recover completely and there's no specific impairment induced by localized damage. Later, after we learned more about the nature of his injury, it was used to illustrate the impact of frontal lobe injury. The story of Phineas Gage itself is actually remarkably complicated, and there's a lot of history there that I won't have time to go into today. Nonetheless, Phineas did suffer a clear, well-demonstrated penetrating head injury. And we can talk about that more at the very end if there's time, and if there are specific questions about him. Closed head injuries are far and away, both epidemiologically and in my experience, far and away the most common form of brain injury. And this happens when the brain rapidly accelerates or decelerates within the skull. This tends to occur when someone in motion strikes their head against a stationary object. Somebody runs headlong into a brick wall, they'll have a closed head injury. When someone at rest is struck by a moving object, if you're sitting at a stoplight in your car and you get broadsided and your head is struck by the moving object. Sometimes you're in motion and an object is in motion and the two collide. All of that can generate a closed head injury. Importantly, that acceleration and deceleration of the brain within the skull is not necessarily dependent on being struck in the head. In whiplash injuries, there is sufficient acceleration and deceleration of the head, even without something actually striking the head. Closed head injury mechanics can be complicated and multifocal. We often think, or in lay situations, we often think, well, he rear-ended the car in front of him and he struck the windshield. So the natural inclination is to believe that, well, all the damage is in the frontal lobes. It's where his head hit the windshield that all the damage is. But that's not exactly true. It's not uncommon to get regions of damage at opposite ends or opposite sides of the brain. This is often referred to as coup and contra coup injuries. The coup injury occurs when the brain accelerates within the skull toward the point of impact. So if you are moving forward, your brain is at rest within the skull, you strike the windshield and the brain then accelerates forward within the skull and hits the inside of the skull. Contra coup injuries happen when the brain itself, a very gelatinous, elastic substance, then rebounds and impacts the opposite side of the skull. This animated GIF is sort of the best example I have ever seen of a coup contra coup injury. I don't know if you can see my pointer here, but as this model skull hits his hand, the brain accelerates forward into the inside of the front of the skull and then bounces back and strikes the back of the skull. So you get a coup injury at the front of the brain and a contra coup injury at the back of the brain. It's also important to understand that the internal surface of the skull, especially the floor of the skull, is a very unfriendly place for the brain. It's full of sharp, bony edges that are just not friendly to the soft, gelatinous texture of the brain. The physiology of the injury is also very complicated. In addition to the direct impact within the brain, within the skull, as that brain sloshes and stretches back and forth, axon fibers, the fibers that connect various regions of cortex and allows various regions of cortex and the hemispheres to communicate with one another, those axons get stretched and torn. Capillaries can get stretched, torn, and rupture. When that happens, that spills blood products and other noxious substances that otherwise wouldn't pass through the blood-brain barrier. All of that substance that's usually not in the brain can get dumped into the brain. When those axons get stretched and torn, they also tend to dump neurotransmitters, particularly excitatory neurotransmitter, in excess into intracellular space, and that causes a cascade, used to be referred to as a glutamatergic cascade, but it's actually a little bit more complicated than just the release of glutamate. And so we get both primary injuries, which are the sites of physical impact of the brain within the skull, and we get that stretching of neurons. Those are all examples of primary injury. And then secondary injury are all of the things that happen next. The swelling, the glutamatergic cascade, all of those things in and of themselves can wreak havoc within the brain and cause additional damage. When we talk about focal injury, again, we're just talking about primary brain injury and secondary brain injury. With diffuse brain injury, the primary injury is the traumatic axonal injury, the shearing, the stretching of those neurons, and the associated secondary brain injury may involve neuronal injury or death, swelling, ischemic injury, hypoxic injury, and metabolic dysfunction. When we're talking about focal injury, when the brain, the coup and contra coup injury, we're talking about focal cortical contusion, intracerebral hemorrhage, extracerebral hemorrhage, the subdural and epidural hematomas, and focal vascular injury. Associated secondary brain injury includes delayed neuronal injury or death, focal brain swelling, ischemic injury, hypoxic injury. Just as an example, when the brain begins to swell, it's constricted by this very rigid skull. And as the swelling progresses, it can further cut off blood supply, which then creates secondary ischemic injury. So it gets really nasty really fast, particularly in moderate to severe brain injuries. Despite our impulse to think in terms of mild, moderate, and severe TBI, this is remarkably complicated. There is no universally accepted method for grading brain injury severity of any type. It's important to bear in mind that the mechanisms of injury, as I said earlier, are not mutually exclusive. So trying to rate a brain injury as mild, moderate, or severe when there is both penetrating injury and closed injury, or blast injury and closed injury combined, it just gets so complicated that a simple label of mild, moderate, or severe is generally not very helpful and may not be useful in terms of predicting outcome. Part of the problem, as I said, is the extent of overlapping characteristics and outcome from these very complex injuries. When I review medical records in brain injury cases, other than an occasional designation that in a particular case, this is a mild TBI, I rarely see physicians in medical records referring to a particular patient's injury as moderate or severe. More often than not, what they're describing is the Glasgow Coma Scale score, the length of post-traumatic amnesia, the duration of loss of consciousness, regions of the brain identified as damaged on CT or MRI. While these can be condensed into a simple indication of severity, mild, moderate, or severe, those are probably just not very useful indicators individually. So I just don't see them very often. What you see, for example, is something like patient suffered a left frontal subdural hematoma and right parietal cortical contusion. So it more often than not in medical records, there is a description of the injury rather than a simple designation of mild, moderate, or severe. Clearly, some brain injuries are worse than others, but there are so many variables relevant to outcome that a simple rubric of mild, moderate, or severe is generally unhelpful. Variables associated with outcome vary as a function of mechanism, whether it's open, blast, or closed, age at the time of injury, sex of the individual who experienced the injury, genetic status, history, medical history, all are significant variables amongst many others. The one exception in this issue of categorizing or characterizing injury severity really has to do with mild TBI or concussion. As I said before, there's no useful distinction or meaningful distinction between mild TBI and concussion, so I will be using those terms interchangeably. There are numerous diagnostic schemes for mild TBI. There are diagnostic schemes published by CDC, by World Health Organization. VA and DoD have their own mild TBI definition, and the American Congress of Rehabilitation Medicine, I'm sorry, I think it's the Academy, American Congress of Rehabilitation Medicine, ACRM, each have their own definition of what constitutes a mild TBI. They share, the reality is each of those sets of criteria share more in common than there are meaningful differences between them. I'm often asked, well, which is the best diagnostic system in a forensic context? I don't know that it matters. There's really, in my opinion, in my experience, there's remarkably little difference between them. I do not recommend picking and choosing. I recommend picking the diagnostic criteria that's already in use in that particular defendant's medical records, or if there is no specific diagnosis mentioned based on a specific criteria or type of criteria, then I would pick a diagnostic system that makes sense in the context of that particular case. Make that decision based on a fair and objective rationale. Describe why you used that particular system, and be prepared to defend that choice on cross. You don't want to cherry pick to make the outcome more favorable, I think, to any particular defendant. I will review quickly the World Health Organization criteria simply because it's fairly straightforward and makes sense. According to World Health Organization, this was their 2005 criteria. A mild TBI is an acute brain injury resulting from mechanical energy to the head from external forces. So basically, there must be a biomechanically plausible event, and that's really important. You have to have a credible event that causes the clinical signs that I'm going to talk about. Being hit in the head by a Nerf dart, that doesn't get it. That's not a biomechanically plausible event. Getting hit with a brick, that'll do it. So the event, there has to be an event, and it has to be a biomechanically plausible event. And then there have to be basically two general clinical signs present. The first is one or more of the following. So you have to have a biomechanically plausible event, and then have one or more of the following: confusion or disorientation, loss of consciousness for 30 minutes or less, post-traumatic amnesia for less than 24 hours, and/or other transient neurological abnormalities such as focal signs, seizure, intracranial lesion not requiring surgery. And then the second clinical sign involves the Glasgow Coma Scale, and you have to have a score of 13 to 15 after 30 minutes post-injury. So what will often happen is you might have someone who is hit in an accident, and their initial Glasgow Coma Scale within 5 or 10 minutes of the injury looks really, really bad. And that's may just simply be because they're unconscious, which is an important observation, but that in itself is not determinative. So they wait 30 minutes and they look at that GCS score after 30 minutes. And that GCS score has to be between a 13 and a 15. If medical attention is sought in the TBI in question, and it isn't always in forensic context, and that's part of what makes things complicated, and we'll talk about that in a minute. But if medical attention is sought in the wake of an accident, that GCS score is almost always listed in either the EMS run sheet or in the emergency department admission record. So I would look there for a GCS score. It'll also tell you, if you look at both the EMS run sheet and the ED, the emergency department admission record, it'll tell you, typically it tells you when the injury occurred, and then those GCS scores are time stamped within the medical record. And so you can see, are we 30 minutes past the time of the injury, and you can see what the GCS score is there. I talked about the CDC and other criteria. The ACRM criteria, the original criteria, were published in 1993, and they are currently under revision. And I don't know what the timeline is, if they have been approved by, the revisions have been approved by ACRM yet or not, but they will probably be published here relatively soon, I believe. This is probably the most important point I can share with attorneys and others who don't have a lot of experience in traumatic brain injury or in diagnosing traumatic brain injury. These diagnostic criteria, these clinical signs that I just talked about, rely on clinical indicators contemporaneous to the brain injury. There is nothing I can do weeks, months, years later that can diagnose a brain injury retrospectively. The neuropsychological measures that I use, that anyone use, are not diagnostic of a historic injury. What matters are the signs and symptoms at the time of the injury. That's what the diagnosis is based on. In light of that, it's critical that attorneys and their investigators do the best they can in obtaining any and all medical records pertaining to that claimed injury. In reality, for the last decade or more, at least, that's actually not that hard. Many hospitals and doctors' offices have been using electronic medical records for at least 10 years. I actually had a case, one of the earliest cases I did more than 10 years ago. This individual was injured 40 years ago, and they were actually able to, now they were handwritten records back then, but they were actually, the attorney and the investigator was actually able to obtain those records for review, which was really critical in that particular case. So what if records are not available? What if the individual did not seek medical attention for what he's referring to as a TBI or concussion? Well, there are ways around that. There are a variety of concussion questionnaires, the SCAT, for example. There's a semi-structured interview, the Ohio concussion interview, I think it's called, or just good, thorough clinical interview that reviews his or her symptoms and the clinical signs at the time of the injury. I would also not just rely on what the defendant is telling you. As with all things, collateral interviews are critical. Interview parents and siblings, friends, coworkers, whoever knew the client at or around the time of the actual injury. Let's talk quickly about incidents. Actually, let me skip into, well, in terms of incidents, numbers vary according to source. They vary according to the age ranges that are included, the location or country, whether we include ED visits or only, or whether we are including all mild TBI incurred. Nonetheless, the numbers are really staggering. Some older CDC numbers suggest that there are about 1.5 million new TBI cases every year in the United States. And approximately 1.1 million of those, the vast majority of those, are all mild TBI or concussion. More recent numbers from other sources suggest that mild TBI occurs in about 300 out of every 100,000 individuals, which appears to, those are newer numbers. And that seems to support the CDC data based on US population. However, that number changes dramatically by age. For example, 16 to 20-year-old males have an incidence of mild TBI of 835 per 100,000 individuals. 16 to 20-year-old females have an incidence of about 726 per 100,000 individuals. And it's not altogether surprising given the propensity for risk-taking behavior amongst particularly 16 to 20-year-old males. The prevalence of all TBI in the general population is about 8.5%. However, for the purposes of this presentation, it's important to understand that TBI prevalence, all TBI prevalence, is markedly higher in criminal justice involved populations, both in incarcerated populations and in community samples. There's a meta-analysis published by Farrer and Hedges in 2011, which indicate that the weighted average across studies is about 41% of justice-involved individuals have a history of TBI, as opposed to the 8.5% in the general population. So TBI is significantly overrepresented in criminal justice samples. Moving on. When we are talking about mild TBI, symptoms may begin to appear within minutes or hours of the mild TBI, and they might include a combination of altered mental status, for example, feeling confused, feeling disoriented, feeling dazed. Symptoms may include, may be included physical symptoms, headache, nausea, dizziness, balance problems, vision problems, sensitivity to light, sensitivity to noise, and cognitive problems, feeling slowed down. We hear a lot these days, especially in the wake of COVID, of mental fog or brain fog. That too is not uncommon in mild TBI. People may report difficulty concentrating, they may have memory problems, and there may be acute emotional reactivity or lability in the minutes or hours following concussion or mild TBI. Though these acute symptoms may be associated with mild TBI, they're also notably non-specific, right? I mean, we don't have to have a mild TBI or concussion to feel confused or to feel disoriented or feeling dazed. We don't have to have a mild TBI or concussion to feel slowed down or to experience brain fog. As I just said, a lot of people who have COVID or who have had COVID are reporting brain fog. That's a whole other conversation for another talk at another time. These symptoms can be caused or exacerbated by other factors, as I said. A plausible injury event and the presence of acute symptoms in the absence of clear evidence of any of the clinical signs noted above might reflect that a mild TBI has occurred. However, the clinician, the forensic examiner, should have considerably less confidence in the accuracy of the diagnosis if those original clinical signs, the diagnostic criteria that I mentioned previously, can't be documented. In the context of mild TBI, once the acute injury phase has passed, hours to days, symptoms should improve over time. They generally don't get worse. I'm going to use a lot of caveats and try to soften that language a little bit, but generally speaking, in the vast majority of cases, symptoms from concussion get better. They don't get worse over the long haul. In my reading of the literature and in my experience, according to the most rigorous meta-analyses that I'm aware of, the vast majority of patients should be mostly recovered within 3 to 6 months. Insofar as cognitive, behavioral, and emotional symptoms are concerned, symptoms that persist beyond about 3 months have been found to be associated generally with pre-existing conditions, mental health, behavioral conditions, or litigation status. There are a lot of qualifiers and caveats in that statement. There will be some who disagree with that conclusion. And let me be clear, there are other symptoms that may legitimately persist. Headache may persist beyond that. Vision problems may persist. Balance issues may persist. But these are less frequently assessed by neuropsychologists. These are usually not balance and vision problems, and headaches are not sort of the main thrust of what we do as neuropsychologists. And I believe they are less relevant symptoms in criminal forensic contexts. What is most relevant in a criminal forensic context are the cognitive and behavioral symptoms, not the vision problems, not the balance issues, not the headaches. So here's some data from Grant Iverson's chapter in the latest issue, the latest edition of Brain Injury Medicine, which is a great textbook. If you don't have it, I highly recommend it. The top of this figure shows the relative deficit in specific domains over specific intervals following a mild TBI. And these numbers are standard deviation units. They're effect sizes. So effect sizes that are 0.3 or less are indicative of findings that would be difficult to identify in individual patients. They are small effect sizes. And the reason they're difficult to identify in individual patients is due to the significant overlap in the distribution between patient groups and control groups. When effect sizes are that small, those distributions overlap a tremendous degree. They're also hard, these effects, when effect sizes are that small, are also very hard to assess in individual patients because of the relatively modest sensitivity and specificity of our neuropsychological measures and the complexity of the actual cognitive processes and behaviors that we're trying to assess. The data that I'm going to present in this next few slides are from Grant Iverson's work, and they're taken from a variety of studies, not necessarily his studies. The bottom pane provides a point of comparison. So we can see, actually, let me just back up for a second. So in sports-related concussion, within 24 hours of that concussion, there are pretty marked, dramatic declines in cognitive function in a variety of domains. It's almost a full standard deviation. So those who suffer a sports-related concussion within 24 hours are experiencing performance at about a standard deviation below the control non-concussed sports or athlete comparison groups. For mild TBI, within 0 to 6 days, you get a decline relative to a comparison group of about 0.4 standard deviations. That's getting pretty small. Within 1 to 3 months, in mild TBI, in some mild TBI studies, you get effect sizes of 0.12. Another study shows effect sizes, again, in mild TBI of 0.12. I'm not going to go through all of these, but you can see these are all relatively small. These mild TBI outcomes are relatively small as compared to moderate to severe TBI after 2 years. These folks are still having fairly dramatic, at least in some cognitive and behavioral domains, a fairly significant decline in function relative to controls. The bottom pane, again, just provides other examples, other comparison groups, individuals in litigation. frequently show overall performance in various cognitive domains of a half standard deviation below controls, non-litigants. Those who malinger are about a standard deviation below. Adults who are survivors or who had experienced childhood maltreatment, their executive functioning is 0.4 standard deviations below controls. So these are just a variety of comparison groups that we can see. Here's another group: type 2 executive functioning in type 2 diabetics, verbal memory in type 2 diabetics, fluid reasoning in those with untreated sleep apnea, executive functioning and set shifting in those with sleep apnea, executive functioning in folks with PTSD, and so on. I'm not going to go through every single one of those, but there are some interesting comparison groups there. Some caveats. There will be some who take issue with a lot of these findings, as I said before. And this is part of a long-standing debate regarding mild TBI. That is, whether or not there are long-standing deficits following mild TBI. That debate will not likely be settled anytime in the near future, and certainly won't be settled here today. The point that I'm trying to make, that I think is worth making, is that mild TBI is but one of many conditions that might induce some impairment in cognitive function. And so great caution is warranted in attributing observed weaknesses in a criminal defendant to a historical TBI without first ruling out a host of other conditions that might also contribute to that impairment or that cognitive and behavioral weakness. Some of the most theoretically relevant, second caveat, some of the most theoretically relevant brain injury related deficits in the context of capital mitigation are, in my mind, the most difficult to assess objectively and free of examiner bias and patient response bias, and that's executive function. Particularly in the context of real world activity, our evaluations are often over-controlled contexts and don't adequately capture real world or real life decision making. They don't adequately assess real world impulse control. So some of the symptoms that are potentially most mitigating, we are not great at measuring. And I don't, as a third caveat, I don't want to give the impression that concussion doesn't leave its mark on the brain. There is increasing evidence that there may be long-term and even permanent pathophysiological changes following mild TBI. For example, energy metabolism, neurotransmitter function, particularly acetylcholine function seems to be diminished after closed head injury. The point I'm making here is that this appears to have negligible permanent impact on an individual's behavior and cognition. So, is concussion a significant mitigating factor? Well, ultimately, it's up to the jury, right? I mean, they're the ones that decide whether or not something is actually mitigating or not. But as professional mental health, forensic mental health professionals, we have to be honest and objective in what we are presenting. It would be hard for me to present to a jury the idea that a mild TBI or concussion years or decades earlier, without any cognitive or behavioral consequence, is in any way meaningfully mitigating. So are there any circumstances, are there any ways or times or circumstances in which concussion might be mitigating? And I think there are. For example, when the offense is committed in the acute aftermath, it is not hard to imagine a circumstance in which someone is in a car accident and is severely concussed in that accident, gets out of their car, gets into a brawl, and somebody dies. could that concussion in that circumstance, in the acute aftermath of the concussion, which may have no permanent consequence later on, could that be mitigating? I think potentially that could be mitigating. I think for me, at least in my experience, I think the most relevance that concussion has in that we see it as a symptom rather than a cause. Remember, when people do stupid things, when people are impulsive, they get brain injuries. And so the brain injury itself, the concussion itself, may not ultimately be mitigating, but the concussion may be the consequence of a long-standing pattern of impulsive, dysregulated behavior, and that history of impulsive, dysregulated behavior might be used as a more potent mitigator than the concussion itself. So consider the possibility that the concussion is a symptom rather than a cause. In circumstances where there's a co-occurring PTSD that goes along with the mild TBI, the PTSD might be the more relevant mitigating factor. As I mentioned quickly just a few minutes ago, acetylcholine, one of the critical neurotransmitters for learning, memory, and cognition. There's some evidence to suggest a fundamental cholinergic deficit following closed head injury that is sort of subclinical. And in the aftermath, once you recovered from concussion or TBI, that cholinergic deficit, that subclinical cholinergic deficit may still be present. And any number of compounds, drugs or medications or anything else that we use may have an adverse effect on that cholinergic system, essentially revealing an underlying cognitive deficit. So it's important to understand what other medications and or drugs they're using at the time of the crime and whether or not that may have exacerbated a pre-existing TBI. And we are 2 minutes from the very end, so I'll say something very quick about CTE and repeated injury. So the question often arises, well, my guy didn't have one TBI, he had 15 TBIs. The popular press has made this idea of CTE and repeated injuries incredibly compelling. And the reality is that science is very complicated and it is not universally accepted. There was a big conference, Keith Owen Yates and others, I would think Grant Iverson was part of it, of a sports-related concussion working group. I think they met somewhere in Europe, and they are in the process of releasing some policy statements and other things sort of in response to this idea of CTE and repeated injuries. The bottom line is you don't want any TBI. You certainly don't want more than one, but how many matter and how many are required to develop CTE? Nobody knows really. And CTE can't be diagnosed, is not diagnosed in living individuals, although there are proposed diagnostic criteria. There's very little evidence that those proposed diagnostic criteria are ready for prime time. So that's all I'm going to say about CTE and repeated injuries. It's incredibly complicated, and maybe it matters, maybe it doesn't. I'm just not prepared to go there. So we're at 2 o'clock on the nose. Are there questions? And as I said, this is all part of a series that I am developing. So your comments and feedback are very much appreciated, either in the comments here or via email or telephone. Happy to talk to anybody about anything. So that's it.
Thank you, Shawn. Yeah, we have a lot of questions. We are right at 12. So anyone who needs to head out, the CE link is in the chat. So feel free to click on that, and just remember you have about 48 hours to fill out that survey. And yeah, so if you're able to stay on for
Absolutely, sure.
Excellent. So I actually had a question regarding the last point that you were touching on. So somebody was wondering about kind of the cumulative effect of multiple mild TBIs and behavioral changes, and cited, football players having reports of these long-term behavior changes. So if you're able to kind of elaborate on that a little bit more.
Sure.
Something people
Sure.
are interested in.
It's an incredibly important point, and there are both important and notable cases, both for football players who have committed suicide, as well as football players who have committed murder. The one that comes to mind is Aaron Hernandez, former University, I believe he was a linebacker for the University of Florida. This is obviously not a random sample. These are individual cases. Repeat TBI has a cumulative effect. I don't think anyone would argue that it doesn't. What matters is severity and timing. TBIs that occur in rapid succession are more likely to have cumulative effect than TBIs that occur at 1 year, 2 year, 5 year, 10-year intervals. And when we're talking about college, high school, professional football players, we're not talking 5, 10, 15 concussions. We're talking potentially about many more than that, especially subclinical impacts. These guys take thousands of impacts over the course of their career. And so it's not something that should be ignored and not something that should be discounted. My point is simply, I don't know that we really and truly understand enough of that pathophysiology that I feel comfortable commenting on that in a forensic context. It's just really complicated. It's probably not a very helpful answer, but.
Sure. No, I think that makes sense. And something related to that, somebody was wondering if at the age that the concussion or TBI is sustained impacts, the damage or long-term impact.
Again, it depends on the nature of the injury itself and the age at which it occurs. We have this, I think, misguided notion that if you're going to have a brain injury, have it when you're young. The brain is more plastic. That doesn't always play out. It really depends on what's damaged, how severely it's damaged, and what interventions are provided in the aftermath of that. Developmental sequence, developmental course, developmental trajectory can be dramatically altered in pediatric TBI. And so don't have one at any age.
Okay, so some people are also wondering about the effects that a concussion could have on developing other types of conditions, and we're wondering about the possibility of potentially developing seizures or acquiring dementia.
Yeah, so, okay, two things, seizures and dementia. Seizures can certainly develop after TBI. Seizures are actually more common, more likely to occur after penetrating injury than closed head injury, but they can occur. Seizures are unlikely to develop after mild TBI or concussion. The propensity or the probability of developing a seizure disorder goes up as the severity of the closed head injury goes up. So seizure disorders are more common after moderate to severe brain injury, closed brain injury, than mild brain injury. With regard to dementia, it was long believed that mild TBI, and particularly repeated mild TBI, is a risk factor for the development of subsequent dementia. I think there is some literature out within the last few years that actually may call that into question. So I don't think, although that was sort of a mainstay belief in neuropsychology and traumatic brain injury science, I think we're rethinking that. I think there is newer data that questions just how direct that link is between those.
Thank you. All right, so someone was also wondering, how do you deal with the potentially aggravating nature of possible pre-existing personality features, such as impulsivity, and the issue of future behavioral dysregulation on death-qualified jury deliberations?
You just tell it like it is. I mean, I think those things, and this is getting back to something I said very early, that we were going to come back around to this issue of aggravating features. I think it depends on how things are presented. I often talk about pre-existing impulsive behavior less in the context of personality issues than just as a cognitive behavioral issue. And I think it depends on how it's presented and how it's discussed in the context of your report and your testimony as to whether or not it's going to serve as an aggravator or a mitigator. What's important is that there is some literature that suggests that sometimes jurors see a history of TBI as aggravating and not mitigating, because they see the consequent behavior. And I'm not talking concussion here, I'm talking more severe brain injury. But sometimes jurors will see it because they see it as out of the control of the individual, that the consequences of that TBI are out of the control of the individual. Those individuals are at higher risk for further offending, and therefore they see it as aggravating rather than. So it's about how you present it. And you have to present it, I think, in a very comprehensive way. The reality is behavioral dysregulation, the problem of behavioral dysregulation and impulsivity is at its greatest in uncontrolled contexts, in real life situations, when people, particularly people with brain injury, have rules and structure set for them by the institution. They're often relatively compliant. They are not so dysregulated that they can't manage that behavior in a structured environment. So I think we have to tell the whole story about behavioral dysregulation in brain injury, and that is, in uncontrolled environments, it's a problem. In controlled institutional environments, it's often less of a problem.
So kind of adding on to that, there's a couple of people who noted that sometimes somebody might present to their primary care clinician at some period after the injury, and so maybe at the time of the injury, EMS or ER didn't detect any symptoms, or there might be some sort of external factors like low SES or not having access to resources for immediate treatment. And so there being other factors that, delay them getting treatment. And so rather than, the symptoms getting better over time, is it possible that they might not present right away or might be delayed? And how would you talk about that in that narrative?
Sure. That's absolutely true. That for a variety of reasons, people may not seek medical care for SES reasons. And there are reasons that even in situations in which people do present immediately, the TBI is is not recognized. And it's not hard to think of situations in which there are other traumatic orthopedic injuries that are more life-threatening in that moment. And that those are the focus of ED care rather than the concussion or the brain injury itself. And so what you have to do is you have to review the medical records, you have to interview the client or the defendant, and do your own comprehensive history. It is less common, I think, today, when people do seek medical care, it is less common for a TBI to go undiagnosed. There has been so much attention given to concussion and to TBI. In my experience, it's not often missed. When it is missed, it's because people don't seek medical attention. And that's very common, especially in the guys that we see in criminal justice settings. They're in a bar fight. They got hit in the head with a pool cue or got thrown up, off a deck or something. And they just went home and tried to shake it off. That doesn't mean they didn't have a concussion. It doesn't mean they didn't have a brain injury. It just means they didn't seek medical care for that. As to the increasing symptoms over time, that's why it's important to interview collaterals, because it shouldn't be the case in concussion or mild TBI that symptoms are actually getting worse. There may be a lack of awareness of those symptoms in the earliest phase, and so it may have the appearance of getting worse, but in reality, you don't have good reports. You don't have good collateral reports and of the early symptoms, and therefore it has the appearance of getting worse, but it really shouldn't be getting worse. The pathophysiology of concussion and TBI improves over time. It doesn't get worse over time. There are certainly psychological factors that relate to the injury or the context of the injury, a car accident or so on, that might exacerbate recovery, but that's sort of a co-occurring psychological, emotional phenomenon, not based on the pathophysiology, the biology of the injury itself. You may feel terrible after crashing your father's Porsche, and have a lot of emotional baggage as the result of that. But that's emotional baggage from crashing your father's Porsche, not from the brain injury itself.
Thank you. All right, and I think maybe we'll have time for one more question. I'll try to combine these two together. So someone was wondering if you know if the research on prevalence in criminal justice samples is based more so on self-report or if it's supported by actual medical history. And then kind of related to that, someone was wondering about concerns around malingering and kind of self-reported claims of cognitive complaints.
Right. Great question. Though the meta-analysis that I'm thinking of that I mentioned, the Farrer and Hedges, they actually in their data set, they code or they provide notes as to how that brain injury history was collected. Some of it's self-report, some of it's based on careful clinical interview, some of it's based entirely on medical record review. So different studies have done it in different ways. And absolutely, there's always a concern about malingering and over-reporting or misinterpreting symptoms. And that's why it's important to form an opinion based on the collective information of records, your own interview with the defendant, and collateral interviews of individuals in their world that knew them at the time of the accident. Malingering is always an issue that has to be carefully considered.
All right, well, I think we'll end there. Thank you again so much for your presentation, for your response to all these questions.
Thank you. And again, I've got my email address there. It'll be in the slide set. feel free to reach out. Anybody's welcome to reach out and ask questions or engage in conversation or correct me if I got things wrong. So I look forward to hearing from folks if they have questions.
Oh, great. Thank you so much.
Thank you.
We had a few people saying thank you in the chat as well. So we're happy to have you for the
Yes.
second time in our series. So
Thank you and happy Thanksgiving to everyone.
yes, you as well.
Thank you.
I will see everyone next week.